Okay, so I know this patient is in the audience. She was 54. She's 50. Oh no, she's 60 something now. 54 at the time of metastatic breast cancer. Very extensive bone disease. You can see on the bone scan, both her hips, pelvis, all up and down her spine, and quite a lot of disease on her scan. Presented really with about 2 months of pain and otherwise reasonably well. No other cancer anywhere else. She was fortunate at that time that I had a phase 1 trial that was kind of a phase 2 trial. I won't discuss it, it's too complicated. Where every patient that went into the trial got the drug. Absolutely fabulous trial for her. So she got into the trial, she got the drug with a cyclin-dependent kinase inhibitor. Apart from fatigue and some skin side effects, worked for 4.5 years, way over what the trial said it should. The median response rate, the median progression-free survival for this particular CDK inhibitor was 25 months. She got very nervous at 25 months because she thought any minute I was going to tell it it stopped working. Went for 4.5 years. So that's the good news. At the time it progressed, her symptoms developed really quickly. It was she came and saw me a little bit earlier than usual. She didn't actually think she was all that unwell. But I took one look at her. She had lost about 3 kilos. She wasn't jaundiced, but her liver function tests were a bit abnormal. So I was really worried it had actually got out of the bones. And sure enough, she had liver disease. And over about a week, 10 days, she actually, partly because I think I told her where the cancer was, she became unwell very quickly. To the point, I admitted her to hospital. She was kind of bedbound. She needed 2 nurses to help her because now she was getting a lot of nausea, a lot of vomiting, a lot of pain. And I said to her, you've got to stop that CDK inhibitor. You've got to have chemotherapy. And over the course of about 3 to 4 weeks, she just turned around. She had chemotherapy for 9 months, and then at the end of that, went back to normal health. Now she's on a second-line endocrine treatment, and I just saw her a few weeks ago. She's doing really well. So the lesson to be learned is that CDK inhibitors, fabulous drugs, absolutely one of the key drugs that have changed lives for women in the last 5 years. But it's not the end-all be-all. There is still a role for chemotherapy, and when used at the right time with the right understanding, it can just take women out of a precarious situation and get them back on track. 65 years of age at the time of metastatic breast cancer. She recurred after having had her breast cancer, I think something like 7-8 years earlier. So it was a bit of a long time. And unfortunately, she was a well woman, so she didn't really have a lot of symptoms until she started coughing. And her GP found that a course of antibiotics didn't work. She had scans, and there she had areas of collapse due to cancer, but a lot of little tiny spots in the lung due to cancer. She also had fluid around the lung, and she also had fluid around the heart. And that was probably also what contributed to her shortness of breath and so forth. Now, 3 years ago, most oncologists would have put her on chemotherapy. But with the data from 6 pivotal trials, and because she had a hormone receptor positive HER2 negative breast cancer, I put her onto a CDK inhibitor. Fortunately, she was diagnosed at a time that these drugs were now on the PBS, so she didn't have to have a trial. She's fabulous. The spots in her lungs have diminished. Got a little bit of fluid here, no fluid around the heart. Living a normal life, going on trips, going on holidays. And then this was a younger patient, and this is the important thing to know. So with some of the hormone treatments, it's only effective in older postmenopausal patients. So we were really pleased to be involved in the Mona Lisa 7 trial, bit of a plug for the CDK inhibitor ribociclib, because out of the 6 or 7 international trials of CDK inhibitors, they chose to do a trial in younger women. They didn't want younger women with metastatic breast cancer to miss out on the possibility that a CDK inhibitor would work. So the design of this trial was she had an injection to turn off her ovaries, and then she got the CDK inhibitor and a hormone drug. So she had a large lump in the breast at the time of diagnosis. So that's there between those 2 crosses. That is all cancer. You could feel it. You can see compared to the last bone scan, a lot of bone disease. pelvis, back, and so forth. She's still on the trial now. I believe she might be one of about 15 patients that are remaining on the trial, which is now closed. The drug is registered, and she's going strong at more than 5 years. So certainly an effective drug that is for both younger and older women with metastatic breast cancer. So I thought I'd just give you an update because you always want to know what I'm doing and making sure that I'm concentrating on metastatic breast cancer. So we currently have 32 active ongoing trials. This is actually old, this slide. I think we're up to about 124 clinical trials that I've now done over the last 20 years or so. 23 of our trials are focused on metastatic breast cancer, and I hope that gives you a lot of encouragement that we're spending that kind of attention to obviously areas of unmet need. We've got, some of you may know about the drug fulvestrant, which is a hormone agent, but it has to be given as injection into the bottom. Not particularly nice. And I would say that particularly for Amanda, who has to give it. So we have 3 trials looking at the same class of drug as fulvestrant. So fulvestrant is a SERD, a selective estrogen receptor degrader. And we've got 3 trials looking at oral formulations. And we're hoping that, this is going to, they're all early stage phase 1, phase 2 trials. So it'll be still a while before they go into a registration mode, but hopefully we'll contribute to that. We have 1 immunotherapy trial at the moment with 1 definitely opening in a couple of weeks and a 3rd possibly opening in the next month. We have trials of anti-HER2 drugs. So we've got a trial with tucatinib, the drug that gets into the brain, so we're quite pleased about that. We have a drug in the early breast cancer setting of a new anti-HER2 drug, so we're excited about that. We're very excited with Françoise. Is Françoise here? No. Okay. Françoise and Mary are our fabulous clinical psychologists, and Françoise is helping me with our 2nd study in children, where we're actually going to look at interventions to try and help children of women with breast cancer aged between 14 to 24 reduce their level of distress, because in our first study we found over 30% of children in that age group had significant distress as a result of their mother's cancer. We finished our fatigue trial, so that's on my cards to analyse, and we've got a number of basic science trials that I think are really exciting that I'm doing with my colleagues at Curtin University. I think that's it. Hang on, let me just check. Yes, that's it. Any questions?
Can you go from one CDK drug to another? Like how many are in that list?
There are 3 CDK inhibitors. Currently, there is no good evidence that changing from one to the other, because the first one has stopped working, is effective. You certainly can change from one to the other to the third if you're not tolerating that particular CDK inhibitor, and that's allowed on the PBS. We have 1 trial that we are probably going to open in a few months' time, where they actually are suggesting that they will allow women on CDK inhibitors, when they progress, as long as they've responded for about 6 months, to then go on to their new drug and a CDK inhibitor. And I know that from talking to my international colleagues, have a patient on a CDK inhibitor and a hormone drug, when the cancer stops responding, keeping the CDK inhibitor consistent and changing the hormone drug. So a lot of research is being done. We want to get the most out of this family of drugs because they're pills, they're generally quite well tolerated. We want to keep on using them in the patients who benefit from them.
Why is it that you have situations where a drug might be replaced in a trial? So in the US, it uses a certain drug as part of a 3-pronged effect or whatever, but in Australia, one of those drugs is replaced by another drug, but it's the same.
Have you got an example?
Yes, I do. I can show you. It's to do with the PYNKS
Kinase?
mutation.
Alpelisib?
Yes. So that's been replaced by capivasertib or something.
Okay. All right. So with some of these targeted treatments, so alpelisib is a PI3 kinase inhibitor. There has been some concerns. How can I put it? I don't know whether this is the reason for the replacement in that trial, but there's been some concern in terms of the tolerability of that drug. It causes a very high rate of diabetes. It can have impact on liver function tests as well. We are involved in an alpelisib trial here as well, but it's just impossible. I've screened 6 patients and none of them were eligible for the trial because it's got a very tight criteria. There's also some evidence that different PYNKS inhibitors of the PYNKS pathway can be more effective. So in that situation, the trial that you're talking about, the pharmaceutical company owns the patent for both. So they have the ability to switch. If you had to involve another company, sometimes that's much more difficult. So if something is being changed, so for instance, we had a trial which was really disappointing. We were involved in both of the trials that got reported, and one of them was actually reported last year at the big American meeting, and it met its endpoint. It actually helped women to live longer lives. And so everybody was very excited. This was it's an oral chemotherapy. I had several patients on the trial. And unfortunately, even though the trial met its endpoint, and partly this could be to do with the American politics, and lack of money and COVID and all the rest of it, the FDA declined approval and basically said to the company, you can try again, but we can tell you we're never going to approve the drug. I have never been involved in a clinical trial where, as a result of that American FDA decision, the company actually closed down. Within a week of that decision, and they let me know because they knew I was part of the team that did the pivotal trial. They said to me, look, we've sacked 250 staff members. Our money's going to run out. Our drug's going to stop working. And so I've got 3 patients on their trial. And so basically, we've got access to the most number of pills that they can give us, which is for another 18 weeks, and then it's no more. And that's just, it's heartbreaking because the company's completely disbanded. They have no more staff. No one's going to pick up the drug to try and, it's a lot of money, a lot of effort, a lot of time by everybody involved for a drug that actually worked. And I thought it was actually really kind of a niche kind of drug.
Did they state the reason?
Yes. So unfortunately, it's always easier to look back in retrospect, because of the nature of the trial, and it was a relatively new American company, they actually opened the trial in a number of centres. I'm not going to bias you as an audience as to which region it is, but it was in a region of the world where they don't have a lot of, I can put this very tactfully, they weren't the highest level of robustness in treating patients in clinical research. So unfortunately, the women that were put on the trials at those centres got some pretty nasty side effects. So much so, it actually overwhelmed the side effects in general. We did really well here. All the patients thought it was a really good drug. And it skewed the results. The safety signal came from essentially, I think, three hospitals. And it's not a criticism of the doctors, I'm sure they would have done the best to take care of their patients, but maybe they, weren't used to getting in quickly. And there was one death, but it was adjudicated as possibly related to the cancer rather than to the drug. But side effects was just too unacceptable. That was what the reason the FDA used, which I actually question as well, because they approve a lot of other drugs, which have a lot of other side effects. So I just wonder whether they, cited that as a reason, but they just didn't think it was going to work.
Would you get genetic factors, racial genetic factors that?
Yeah, and that's a good point because, in the days when I used to do a lot of travelling, which I'm so pleased I can't now, there is absolutely differences in particularly Asian patients, not so much Black Americans, but Asian patients have a different metabolism because a lot of these oral drugs are metabolized through the liver. And so we've tried many times to try and initiate collaborations with my friends in Malaysia and in Hong Kong to try and do trials. But unfortunately, there's not a lot of interest in doing a trial looking at safety issues when the drug is already out there. And the drug is out there because 95% of the patients were Caucasians, so they knew what the safety profile was. And so if Asian patients get more side effects, you couldn't really pick it up very well.
What about Indigenous ladies, Arlene? Because we know that they have.
Yeah, I think part of the problem is that they make up a very, very small cohort of trial recruitments. I think, and part of that is the distance, is the belief system, whether they want to be in a clinical trial. And really, one of the things that doctors have to do, and we don't have a crystal ball, but one of our requirements is we have to explain sufficiently to the patient to say, we want you to go into this trial, but we need a commitment from you. So women need to have the information to process, but they have to say, look, I want to be committed to it. And sometimes you go into a trial, it's a placebo-controlled trial, they're getting best standard of care, but they're not necessarily getting the new drug. They think because they don't have any side effects, that might opt for them to come off. But more commonly is if you go into a trial where it's an open label trial, half the women get the best standard treatment, half the women get the best standard treatment and the drug. So everybody knows, doctors and patients know who's getting what. There's also an issue that the patients in the control arm say, look, there's nothing in it for me, And so sometimes they come out of the trials. So if we have that problem with just general population, it's going to be even a bigger problem with Indigenous people because it's a big commitment. It's a lot more travel, potential for side effects. They really have to have the ability to understand what the advantages are for them.
Good to have access, to have funding so that you can go to them. The accessibility wouldn't.
Really hard because, it's not just a matter of travel. You need to have the support systems. If you want to do a trial with a new drug, you need to be able to support that individual in the community. What if they don't have a hospital? What if they have an emergency department? And you can't. One of the basic requirements of doing clinical research is do no harm. You can't involve a patient, even if you think it's the best thing for them, if your social circumstances are such that they may be at a higher risk of harm. And I think that's the biggest problem. I mean, I have patients from who are in regional areas that say, look, I'd really like to do it, but I just can't commit to the travel. And that's a discussion and decision that we make together.